Welcome back to SWAM course on Design Thinking and Innovation. This is week 8 case study. The case study is on the Indian medicine system. Section C8, week 8. The case study is on the Indian medicine system. So, it follows the design thinking and innovation process. The process involves research, analysis, ideation, prototyping and recommendations. The tools involved are brainstorming, mind mapping, user interviews, circular mappings, causal mappings and prototyping. It also is carried forward in the project through secondary research and primary research, use of these tools, prototyping and coming out with recommendations. And then finally, this is the case study.
Orshad, a systems level addressal of the issues identified in the Indian medicine system, especially in the area of patient education. We are team Malayaliano, that is Ishan, Jeremy, Mohak and Prafulla, and this is our culminating presentation for DEP 302 Systems Design. In this presentation, we will cover a brief overview of the existing system and how we mapped and navigated across it. Then we will discuss the scope we set, factoring in the ground reality and existing constraints. After which we will move on to our proposed design solution, illustrating and contextualizing it with scenarios and prototypes. Then we talk to our stakeholders to evaluate our proposal. And finally, we map it onto the existing system to understand how it fits and addresses consequences. Our project focuses on the Indian medicine system, but in order to get a holistic understanding, we had to see it in the context of the larger Indian healthcare system. We identified all the entities and variables in the healthcare system, and from these 8 major entities, we decided to focus on the consumer side of the system. That is distribution, prescription, transparency, usage and tracking, all of which can be better explained as prescription, procurement and usage. Subsequently, we created connection circles of each of these subsystems so as to not lose sight for the granular insights of interconnected elements that make them. Our next step was to clearly identify the problem space, making use of our insights. We gathered insights in 2 ways, through our research and by creating and analyzing comprehensive system mappings. From the research, we clustered issues and insights to narrow down to more definitive issues. And from our system mapping, we were able to extract a plethora of unanticipated insights and connections. So, having identified a variety of problems, we then moved on to look at opportunities for intervention. Of these 5 broad problem areas of OTC access to medicines, patient medical info tracking, consumer medication errors, patient education and rural accessibility, we felt that patient education had the most scope for intervention, and it was also well connected to the other problem areas, so it showed promise as a broad system level solution. Within patient education, we identified 3 major areas. The first is patient effort, which includes some level of independent diagnostic and treatment action by the patient. Secondly, the communication between the patient and the doctor and also the quality of this communication. And thirdly, insufficient attention during consultation. So finally, this brings us to our problem statement, that is to address ineffective communication and documentation regarding patient condition and treatment, and further improving compliance and self-care. Having formulated this, we went forth to identify our target demographic, which is the semi-urban population. So semi-urban towns are places with medium to low income households with limited healthcare infrastructure, where doctors often deal with a high volume of semi-literate patients who may have limited technological access. And within this demographic, we made sure to interview a diverse group of each type of stakeholder, patients, doctors and pharmacists, so that the needs and expectations of each are duly represented.
With this problem statement in hand and our stakeholders identified, we needed to create a solution that would allow for technologically and technically illiterate users, as well as overworked and understaffed doctors and hospitals. We understood that no single solution would encompass or holistically address patient education. So we decided to create multiple modular interventions at multiple stages in the system. Our solution exists in two clear phases. Firstly, we created a service that bridges the issues of patient history tracking as well as registration and file management. This service gives patients a unique tracking number which can be used to access all their medical files and treatment history. It also gives doctors easy access to these patient files. Next, we looked at the packaging of medicines. We made two redesigns, one for chronic patients and one to address common design flaws in bill sheets. Additionally, we created a packaging solution which allows pharmacists to add dosage information and other vital information like dietary restrictions onto the packaging.
To explain our concepts in detail, we will walk you through a scenario involving our primary person. Manju is a farmer living in a small village near the semi-urban town of Gauribidnur. She has chronic hypertension and diabetes and is literate in Kannada. She is visiting a clinic in Gauribidnur to consult a general doctor as she has been suffering from high fever and cold for the past 2 days. Waiting room. Considering the high volume of patients in semi-urban clinics, each patient generally spends about 20 to 40 minutes in the waiting room and only about 3 minutes in the actual consultation. There is a huge scope to make better use of time that patients spend sitting outside to make efficient use of whatever little time they get with the doctor. And hence we came up with the idea of pre-consultation form so that the patients can collect their thoughts and symptoms even before they walk in the examination room. Here Manju receives a consultation form and starts filling it in Kannada, entering whatever relevant information she had. She mentions that there is itching in her throat under the symptoms section and circles the throat area on the diagram as well. Most people, even if they can't read or write about symptoms in detail, can still be functionally literate in marking these on the diagram. And nurse measures the Manju's vitals like BP, pulse and temperature and adds them to the form. And she scans it so it gets updated to the Manju's profile in the central database. Manju then enters the consultation room. She is familiar with the process of Aushad app. She opens the app and scans it, and the doctor gets access to her files. After she scans the code, the doctor sees Manju's medical history, previous consultations, their prescriptions and the OPD notes all at one place on his digital tablet. Even the current chronic medication she is taking and the vitals and symptoms recorded in the waiting room are visible to the doctor to make informed decisions. The doctor can go and write his OPD notes using a stylus, and the app will transcribe it and later translate it into Kannada in simple layman language. And then he can go on prescribing medicines. He can search for the medicines, adjust dosage, course duration and more. Here the app checks for drug interactions and possible side effects with any previous medical conditions or medications. The interface then gives a heads up to the doctor so he can let the patient know about it or just make changes in the prescription. In this example, the app shows the newly prescribed drugs interacting with Manju's BP tablets, as ibuprofen lowers the working power of BP tablets. So it just lowers the course duration and lets the warning stay on the prescription for Manju's reference. Once the doctor has finished prescribing, the prescription gets digitally saved, and a cheap thermal printout copy is also available for Manju. Currently, prescriptions are completely illegible and only work as a token of purchase rather than an important informative medical record. Illegibility is a big issue even for pharmacists, because instances from our primary research show pharmacists misreading the prescriptions and giving wrong medicines to the patients. And the existing packaged information is too generalized and usually written in medical jargon, which might not be relevant for all patients. The app's digital prescription and generation solves all these issues, including showing vitals, medicine name with doctor approved alternatives and easy to read icons for dosage instructions, and the doctor approved personalized warnings in Kannada. When Manju visits the pharmacy to get medicines, the pharmacist can place each individual medicine in these custom pouches and just tick the correct usage instructions. This splits the information from a singular prescription into per tablet basis, so it's easier for patients' convenience. This also helps Manju identify her own medicines and differentiate from other medicines in the house. And when she gets home, the app has already translated the doctor's notes to in understandable Kannada language to help her understand her diagnosis and medicines better. The doctor also suggested a couple of videos for Manju to watch so she can understand her condition better.
Existing packaging has lots of completely irrelevant information, useful to pharmacists but not necessarily to patients. Our proposal for redesigning packaging clearly focuses on the patient's uses, separating legally required information like manufacturer's address and other information aside. And the name, expiry date is printed on the back of each tablet. So even if the pharmacist has to cut the tablet, important information is carried over. We also designed symbols for different medicine classes such as dietary supplements, stimulants, antihistamines, analgesics, etc. Chronic medications are currently packed like any other medicine, but the compliance of these daily medications is very important. And there are lots of human errors involved, like accidentally taking medicines twice, or missing one, or even taking the medicine of someone else in your household. So we designed a tablet strip which comes with day markers to track medicines and offers demarcated blank spaces for patients to write their own relevant information such as date of purchase, etc. While this scenario talks about Manju who has a smartphone, users with feature phones also have equally access to their patient history database, medicinal information, and medical literature in their preferred language using the automated Aushad hotline and SMS service. They can message medcodes and receive all the relevant information as a reply, or use the missed call system to avail audio literature about specific conditions as an automated phone call. All these interventions at different levels in the system ensure that the patient is duly educated about correct usage and potential risks. There is enough redundancy in the system such that even if one intervention were to fail, the other aspects would ensure safe medication usage.
During the ideation and development phase of our design process, we worked constantly with our stakeholders, getting feedback and inputs on our designs. Once we had detailed the concepts to a high degree of fidelity, we took feedback from our stakeholders to each of the ideas in isolation, as well as how the solutions worked on a system scale. First, we spoke to a chronic patient, an adult male who takes medication multiple times a day. They were very appreciative of the central medical database as they had faced a lot of issues when moving hospitals. They did, however, have some issues with privacy concerns and were worried about malicious doctors selling their information to third parties. We plan to address this by using secure means of data transfer and storage, so doctors only have access while a patient is being treated or has consented. They also had concerns about the chronic medication redesign. They were concerned with the English letters on the tablets and said that older people from rural areas might have difficulties understanding them. And we have addressed these to some extent using med codes for each medicine, allowing people to use the internet or the automated SMS service to get personalized medicine info in their preferred language. And finally, we ran the idea through Dr. Chaitanya, who works in a hospital that sees a high volume of semi-urban patients. Since he works in the OPD, he was able to validate our ideas in the exact situation we imagined. Crowded hospitals where doctors get around 3 or 4 minutes per patient. He really appreciated the idea of a central database, drug interaction, heads-up, and redesign packaging. He had some suggestions regarding doctors having control over what part of the OPD notes are shared with patients, as doctors tend not to reveal everything to patients in psychiatric or cancer cases. He suggested that we should also look into the fact that many patients have doubts regarding medication or symptoms, but don't have many channels to contact the doctors or gain relevant information, and they end up asking this in their next consultation, which will usually be a few months away. Apart from this, he wholly agreed to many of our points about the current system and showed massive support and encouragement towards our project, lauding us for our understanding so far. We also did some amount of self-evaluation, and with regard to these symbols, we realized that while their information often empowers users, sometimes it can cause more harm than good as well. Trying to reduce something as complex as medicine types into a handful of symbols is too reductionist and could very often lead to people associating completely different medicines with each other, potentially leading to a plethora of serious medication errors, especially with regards to the elderly. Now that we had detailed all our designs and received feedback on each of them, we were comfortable placing them into our original mapping of the Indian healthcare system. We isolated the variables that were directly affected by our interventions into a subsystem. We then placed our designs into the mapping and drew connections with the variables that were they affected. From this mapping, we saw that patient education, patient history tracking, and overall quality of healthcare all were positively affected by our interventions. We also saw a decrease in medication errors, drug misuse, and adverse side effects of our medication. Special thanks to Doctors Laji, Chaitanya, Ajmal, Karthik Ravi, and Dhwani Ravi for taking time out of their extremely busy schedules and spending their precious free time talking to us. And of course, our thanks also goes to our mentors and faculty advisors, Professor Ravi Poovaiah, Professor Ajanta Sen, and Professor Pramod Kamte. Abhiprayam.
Thanks a lot for listening to the case study on the Indian medicine system. Just to do a summary of the project, they started off with a generalized problem statement. So they had to do overall mappings to understand the problem space, and slowly, step by step, they actually focused and defined the exact area they wanted to work in. And finally, they said that let's do interventions from the user's point of view. So they actually looked at solutions which were available from using a tablet for the doctor to a centralized place where the data is stored to its output on a mobile device, to also interventions at the packaging level. Okay, so another important part of the project was that they actually went what they thought as good solutions and got it evaluated, and they suggested how to actually put this evaluation back into the solutions that they had thought of. Okay, so again, thanks a lot for listening. So this is week 8. We did the design thinking and innovation process with data analysis, part 2 of it. We also did what it is to go from inferences to finally recommendations and redefining the problem. The tools were how to create personas and the OI/OR table and implement it in the design project, and have a look at the design project, the Indian medicine system. Let's look at the week ahead, week 9. We start with the design process, it's ideation part 1, where we'll look at creative concepts, idea brainstorming and idea sketching. And in terms of tools, again, further look at idea sketching, body storming, scamper and lateral thinking, all different methods of coming out with creative alternatives. Implement these in the project and have a look at a case study. The case study is on geolights.